Max Super Specialty Hospital, Delhi. He'll be moderating a session, a case-based panel discussion, ideal management of first-line early stage SCLC. And the panelists are Dr. Rakesh Reddy Boya. He is a consultant medical oncologist from Mahatma Gandhi Cancer Center Hospital Research Center, Vizag. Dr. Satish Sethi from Senior Consultant Medical Oncologist at HCG and SOC Bangalore. Dr. Lakhan Kashyap, Tata Memorial Hospital, Varanasi. And Dr. Bharat Bhosle, Director, Sunrise Oncology Care, Mumbai. Over to Dr. Sajjan Purohit for the further proceedings. This session is sponsored by AstraZeneca.
Thank you, Dr. Kumar and the organizers for having me here Saturday morning. So we are already running short of time, so we'll start the presentation right away. Can we go to the next slide? Welcome all the esteemed panelists, and we start with a case today. So there have been really good discussions in the previous sessions where we have been trying to find what could be the second best line in small cell lung cancer. And we now know that till 2021, the first best line is the the best strategy for small cell lung cancer. So this is a case which has been provided to me. It's a hypothetical case. Age is 62 years, current smoker with history of 30 packs per year, presented with increasing shortness of breath, hemoptysis, weight loss, and early satiety. Patient's primary care physician found massive liver enlargement and found physical examination, and lab work revealed elevated ALT and AST. CT scan showed that left lower lung nodule was there, mediastinal lymphadenopathy was there, and also there was a massive hepatomegaly. The biopsy was done from the primary site. It came out to be small cell lung cancer. Next slide. So to begin with, I'll ask my panelist. So for a small cell lung cancer, I'll start with Dr. Bharat. Dr. Bharat, what is your standard staging system for small cell lung cancer, and what site for biopsy do you prefer?
So for small cell lung cancer, it is very important to define whether stage wise, whether limited stage or extensive stage. So I have accessibility to both PET and CT. So I do a combined PET CT scan, and brain MR is included in all patients to see, because even if the patients are asymptomatic, we tend to pick up those small nodules. So PET CT and MRI is what a radiological investigation.
Okay. Dr. Satish, what about the site of biopsy? Is there a preference for any biopsy site, or whichever is more accessible, you would like to go for that?
See, I'll try to prefer a easily accessible lesion. Either lung is able to peripheral lesion is a, then I'll try to prefer the lung. Otherwise, already easily will accessible lymph nodes, suprachoroidal lymph node, neck nodes are there. Then I'll try to prepare a whole lymph node biopsy for this is diagnostic if it's required, and now we are going for a molecular profile actually.
Dr. Sajjan, okay. I would like to add here one thing. If you have a larger tissue, it is better to have a biopsy from, as rightly said, a whole lymph node. Because recently I have come across two cases where there was a small cell carcinoma lung with 1 or 2 foci of adenocarcinoma. I treated that patient to a limited stage. The patient relapsed. I insisted on biopsy, and it was actually EGFR positive lung cancer at transformation in the subsequent relapse.
So that's one more learning from this. Dr. Rakesh, with respect to MRI, do you recommend MRI for all your patients, or
all my patients, irrespective of whether they have symptoms, of brain metastasis or not. In SCLC, it makes a difference.
Dr. Lakhan, apart from the previous panelists, would you like to add something to diagnosis as well as staging?
Apart from this imaging investigation and the histopathology, for the prognostic significance, I would like to add LDH as a marker apart from that, and the routine investigation, CBC, LFT, RFT, calcium.
Okay. One more thing, like for that Dr. Bharat explained that there can be some transformation of adenocarcinomas into small cell transformation. So do you routinely use next generation sequencing or PD-L1 for your patients, or in the first line, or you would reserve that for a later line? Or you don't do it?
I mean, for the NGS, we don't do it the first time the small cell lung cancer. We tend to do it at the site at the time of relapse. PD-L1, as we have seen both in the studies of the Caspian and in part 133, that it was not associated, it didn't correlate with the benefit from the immunocheckpoint inhibitor. So PD-L1 not in the first line, not in the subsequent line also, but NGS definitely at the later line with preferably with the rebiopsy.
Okay. So I think the takeaways from the diagnostics and imaging is that MRI should be a part of this, biopsy from a more accessible and a probably a larger tissue which could actually have a delineation of the histology, and no role of any NGS at the front line. Next slide, please. So the NCCN guidelines have this as incorporated. So PET CT scan wherever possible and MRI as a part of the initial staging. Next slide. So this patient was imaged with CT scan, which showed left lower lung nodules and mediastinal lymphadenopathy. There was multiple, it was hepatomegaly, but there were some hepatic SOS also. And CT guided biopsy was done from liver, which confirmed metastatic involvement. MRI showed no abnormal findings in the brain. And also there was AST and ALT, which was elevated. Next slide, please. So the question is the very pertinent question today in 2021. So wherever you're setting, if finances are not an issue, then what would be your first choice among the three options? I would say one is IO plus chemotherapy. Among the IOs, we have two options. One is durvalumab, other one option is atezolizumab, and the third one is to go for platinum-based doublet treatment. Or any other suggestion you have. I'll start again from Dr. Lakhan. Dr. Lakhan, first from your side.
If the performance state of the patient is good, yes, 0 to 2. I would, in today's setting, in the extensive stage SCLC, I would go with the combination of carboplatin with etoposide along with immunotherapy. And the immunotherapy it could be either atezolizumab or the durvalumab. The preference would be depending on the depending on the cost and the reimbursement, and definitely if it is covered in the patient's if patient is able to whatever the patient is able to afford. So that with the chemotherapy 4 to 6 cycles, and then continue with the checkpoint inhibitor maintenance. And if the patient has the this would be the choice of the chemotherapy in this setting.
Okay, Dr. Rakesh.
Yeah. So, are you asking for this patient or any patient?
Yeah, the same question for you. So, finance is not an issue. What would be your preferred choice?
Okay, for not this patient seems to be having a very bad liver disease. So here I would start slowly for this patient. I would start with single agent platinum and then build up on the response, and the tolerance. For any patient in general with good performance status and decent organ functions, then the choice is platinum etoposide. I would prefer carboplatin as my platinum of choice. Ease of administration and lack of, it is comparable with cisplatin. So that is my reason of platinum choice. And regarding atezo versus durva, it is difficult to pick and choose. If I'm using carboplatin etoposide, both of them come into picture as per the data. Atezolizumab is easier for me to convince the patient if the cost are being considered. If cost is not an issue, then I can put them on either of the options. Depends on the scenario.
Okay, so Dr. Bharat, I think the first two panelists have been really diplomatic. So I like a blunt answer from you. So what will be your one choice?
So basically,
no constraints. The patient is PS0. Patient has no organ dysfunction. Patient is absolutely fit. Finances no issue.
So, Sajjan, we have to understand this patient is not going to live beyond 1 year if you use whatever is traditional combination of platinum and etoposide. We understand the toxicity is going to happen. As a medical oncologist, our job is not only to give chemotherapy but to monitor the toxicity. Individually, one can take the decision to modify the doses, but the sure shot, best answer is to go with the whatever best shot available in 2021. So I would like to counsel the patient for all the acceptable toxicities, and better to start with the combination and add immunotherapy in the beginning only, because the best answer in today's date, the numbers are with the combination therapy, not.
So which immunotherapy?
Among the two, I am very categorical. Yeah, so I am very categorical about immunotherapy. See, once the patient completes, and we know that most of the patient gets excellent response in small cell lung cancer. You agree with that, right?
Yeah.
The only challenge, the patient coming back to the OPD. So if I have answer that, can I come to the OPD or daycare after 1 month? Yes, then I will choose that drug. Every patient, be it any cancer, ask no, doctor sahab 3 हफ्ते की जगह 4 हफ्ते कर सकते क्या? Now I have an answer. So that is why I tend to use that drug particularly.
Okay, okay. So can you name that drug?
Everybody knows that.
Okay, everybody knows. Okay, Dr. Satish, any difference from Dr. Bharat's? Yeah.
Yeah,
Or you
I'll agree. No, I'll agree. I'll three of our colleagues. See,
He's a
like
friend of mine.
yeah, platinum basis. See, like I'll try to most of people they'll try to use a carboplatin. Like if a very young fit person is there, we can still I try to use even cisplatins, even advanced stage. Not like organ compromise. General condition is good. I will try to use a platinum. Except like see, the both the molecules are having data. We can use any one of them. The one thing is that having the brain mets deep for durvalumab is the preferred choice. The data is more inclining towards the durvalumab preference. If you use like data, if you do have a data towards a platinum in the platinum with immunotherapy combination, the carbo, yeah, definitely both the molecules can be used. Because the see, most of the thing will along with the chemo 3 weekly will be go like both the IO can be used and later like Bharat said like people that try to have like a lenience towards like visiting like delaying that is it is a very practical in our India. Yeah, we can use any one of them. It's a more of like cost is not any one of thing. I think most of people they are trying to have a more experience with atezolizumab than durvalumab because durvalumab is a late comer actually. I think like I've been involved in so many clinical trials with durvalumab. I'm sitting even stage 3 limited stage 4 CTID as a how specific data is there. I'm very happy with this durvalumab and I'm involved in a various molecule. Definitely because the people number of the doctors are exposed to the durvalumab is very less. That's why the people are not ready to open up. Okay, I'll use it. Anyone you can use it. There's not an issue at all. I can really even 4 weekly data is there like durvalumab we can use easily. That's what there's a practicality is easy with the durvalumab. Except the cost is we have to think about this.
So, okay. So what from the panel I can derive is that both the drugs are, I would say there is a choice of both the drugs. However, if cost is not an issue, if the drug accessibility is there and the patient is ready, then preferably go for a durvalumab based platinum doublet, and preferably most people we are favoring carboplatin instead of cisplatin because of the lesser toxicity and probably better experience with the carboplatin instead of cisplatin. Next slide, please. This we already covered. Next slide, please. Next slide. So this I'll ask very quickly. So are there some patients where you would like to avoid immunotherapy? Dr. Lakhan, which are the patients where you would like to avoid immunotherapy?
The patients we don't have the data or those with the symptomatic brain metastasis. Those patients and particularly those who have the active autoimmune disease or who have the neurological paraneoplastic syndrome. I think these would be the patients where I would like to avoid immunotherapy.
Okay. Dr. Bharat, what about paraneoplastic syndrome? Because paraneoplastic syndromes are very common in small cell. So would you agree with Dr. Lakhan or some different take?
So basically the reason for paraneoplastic syndrome, if you see, is the reason of no disease being in the body. So in those cases, we can start with no little bit of care. You can start with the platinum doublet, but once the disease is under control, the paraneoplastic disease is also going to, that syndrome is also going to be under control. And subsequently, individualized decision can be taken, after again. So we don't know the clear-cut biology of the paraneoplastic syndrome. And it is the presence of the disease inside the body and knowing the excellent responses with the platinum doublet, subsequent decision can be taken to add, though we don't have a data.
Okay, so I think there are 2 points. One is symptomatic brain metastasis. I'd just like to add, if there are symptomatic brain metastasis, always better to start with the whole brain radiation or SBRT, depending upon where they are located and how many they are. But once that is controlled, we can actually switch on to the conventional setting which we are talking about. And there are very few contraindications to immunotherapy in the real world, especially autoimmune settings or a patient who has had prior immunotherapy for some other cause. could be one of the possibility where contraindications there. So we have seen that so many trials have failed and still they keep failing. Even the last two abstracts, we saw that there's not great data even with the targeted drugs. But then these two immunotherapy agents, durvalumab and atezolizumab, have shown improvement in OS, and that has made these as the first and approved indications. Next slide. So now why it is so important to add IO in the first line setting is because many of the small cell patients will not be able to take second line. Almost second line will be only receiving 30 to 50%, and beyond second line, less than 20% patients will be live to have the third line. So it is always better to use the best treatment with the best combination in the first line. Next slide. And this is what is reflected in the NCCN guidelines also. Next slide. So these are the options which we have. Next slide. Next slide. Next slide. Next slide. So there are certain indicators which can help us decide. So with both these studies, we know that both the studies have shown and they met their primary endpoint. With durvalumab, we have now long-term data of 1 year, 2 year, and 3 year OS, where 1 year OS was 52.8%, and even at 3 years, the OS was 17.6% compared to the comparator arm, which was only 5%. However, in atezo arm, we only had the 1 year OS reported. The 2 year and 3 years OS data is not reported till date. So that's one of the indicators which can help us choose among which drug might be preferred as the preferred IO. Next slide. Also, if we just compare Caspian versus IMpower 133, there are certain subsets which were not included. For example, one was that the untreated brain metastasis were included in Caspian, whereas they were excluded from the IMpower 133. Also, PCI was excluded, so there was no need for PCI, or it was a kind of a challenge which the Caspian investigator took, that they will not allow PCI in the experimental arm and see whether durvalumab is able to cover the penetration of disease into the brain. Also, up to 6 cycles were given. So normally, many of us tend to, when we were using only chemotherapy, we were giving 6 cycles, 4 to 6 cycles. So even up to 6 cycles were allowed, and cisplatin was allowed. So these are certain indicators which are different in these two trials, and based upon these criteria, the Caspian study was more, I would say, more near to the real world practice. Next slide. Next slide. So, okay. So if you just see the curves here, so you could see that if you see the IMpower 133, the curves start again coming back around 18 months, and beyond that we don't see any separation of curves going on. Whereas in Caspian study we see the curves start separating as early as 3 to 6 months, and they continue to have a kind of a parallel run. And even at 2 years, the difference was around 8%. And at 3 years, the difference in OS was 3 times. That means at 3 years, the median OS in the comparator arm was only 5% compared to 15% in the experimental arm. So these are some data which could actually help us understand which could be a preferred drug when we are using these drugs in a clinical practice. Next slide. So based upon this data, we now know that durvalumab is the only IO which demonstrates 3 year OS, which is significantly, I would say, higher compared to the comparator arm. So you can see here 5.8% in the comparator to 17.6%. Next slide. Next slide. So the patient received systemic treatment with cisplatin, etoposide, and durvalumab, and completes 4 cycle, had a complete response of the liver lesions. Then patient, as Dr. Bharat was very happy to call every 4 weeks, was put on a 4-weekly maintenance, and patient was closely monitored with serial scans every 3 months, and there was no evidence of progression. Next slide. So coming to the next question. So I'll start with Dr. Bharat. If you're using IO, and if you're not using, for example, Tecentriq or atezo, with durvalumab, are you still incorporating PCI, or what is your practice in your clinical practice? Is PCI in your practice with IO or not? Dr. Bharat.
So we know that these patients tend to relapse in the brain. So as a standard practice and our experience of decade, is important rather than what little experience we have with immunotherapy. So I consider all the patients for prophylactic irradiation.
Okay. So you add PCI. Dr. Lakhan?
So, I mean, we have the data also that if we do the MRI surveillance, I mean, there would be increased risk of CNS progression. However, the OS is not different. So, if we and because these most of the patients are elderly, and with the PCI, there is a risk of neurocognitive decline. So, and if the patients follow up, if we know that the patient will come for the follow up, we have the facility for the MRI. With the current statement, I would go with the surveillance MRI every 3 months, and
Okay.
if
The
so, for
surveillance
pediatric population.
MRI for you. Okay. Dr. Rakesh?
Yeah,
Surveillance
it depends
MRI
on
or PCI?
it depends on the patient. If the patient can come once in every 3 months for the scans rigorously and they understand
No,
the importance of
patient
it.
is coming monthly because patient is on durvalumab.
Okay, fantastic. So definitely surveillance MRI.
Surveillance MRI. Dr.
Yeah.
Satish, PCI surveillance.
Yeah, I'll try to incline to do, but I'll try to decide case to case basis. Still my practice is a PCI. I'll try to give it. Yeah.
So our panel is divided. We have Dr. Bharat and Dr. Satish who are more inclined towards adding PCI. And the other two panelists would be more happier doing brain surveillance. I think we all need to have that confidence with durvalumab, as Dr. Satish rightly mentioned. The more and more we start practicing, because in the trial it has shown that PCI can be safely given away with durvalumab. But yes, we will need some more time to change our practice from PCI to brain surveillance. Next slide, please. Next slide.
Just request to finish the session in the next 1 minute.
Yes, 1 minute. Yeah. Okay. So, so just go back to the last slide. Yeah. So, how it is that with PCI, the data was based upon these two trials. So there was some benefit in one trial, which was the landmark trial Stockman study, but from the Japanese study, there was no benefit of adding PCI in the different patient population. Next slide. Next slide. Next slide. Next slide. So, thoracic RT also. Just one word with respect to thoracic RT. So, Dr. Bharat, thoracic RT in your patients, when do you add or you don't add?
So as no before use of immunotherapy was prevalent, we used to consider local RT also. But now if I am using immunotherapy, I have to be very careful because this will add no additional toxicity of creating radiation pneumonitis. And at some point of time, there is going to be confusion whether it's immune-related pneumonitis or post-RT pneumonitis. So then I would like to avoid if I am using the immunotherapy.
You like to avoid. Dr. Satish, thoracic
Yeah,
RT in a very good responding disease, yes or no?
No, I won't do. I'll try to do it. The patient is doing very well, showing a progression primary. That time I'll try to add, not the good responder.
So,
patient. Yeah.
okay. In the interest of time, yeah, I'll only take 2 panelists for this. So, we don't know in the era of immunotherapy whether RT adds benefit. Next slide, please. Next slide. Next slide.
Dr. Sajjan, one point, if
Yeah.
you consider both PCI and thoracic RT, both of them don't have any data in the era of immunotherapy. So only data to suggest overall survival benefit comes from thoracic RT. I think we should still consider thoracic RT if there is residual disease in chest only with, well-controlled systemic disease elsewhere.
Point well taken. Next slide, please. This is the last question. So, patient had brain metastasis at diagnosis, supposedly. The patient was symptomatic. We already discussed symptomatic patient. We were treated. Asymptomatic patient, we can just start with the IO plus chemotherapy. Next slide. So, there's one point I would like to draw. Next slide, next slide, next slide. Next slide. Yeah, okay, just here. So this is one. Go back. So this is one data from the Caspian study, which shows that even in patients with brain metastasis, the combination had a much better survival compared to the EP arm, 12 months versus 8.8 months, and you just see. Compared to the patient with no brain metastasis, 13 months versus 10.5 months. That means Caspian study showed that if the patient even had brain metastasis, there was some additional benefit of durvalumab if the patient was symptomatic or asymptomatic. So probably it prevents further brain metastasis once the brain metastasis are controlled with radiation. And this could be one interesting takeaway from the Caspian study, because in the IMPOWER 133 there was no data with brain metastasis. So many of our patients will fail in brain. So with IO, especially durvalumab EP combination, there's a good chance that these patients can do better compared to their peers. So I'll stop it here in the interest of time. Thank you so much. Any last comment from any of the panelists is okay. Dr. Bharat or Dr. Satish, any points?
Satish, you can go ahead.
No, I think like he has made all the things discussed entirely. Like I want to see that we have to choose. Like see, I said even previously the brain meds. Yeah, you can have try to you can any one of the molecule you can use. Brain meds, I'll try to have durvalumab, but I'll try to have more like a bias because I'll try to have like I have done so many studies with durvalumab and having good experience in trial and those things. Yeah, if you come with a clinical picture, I'll try to prefer a durvalumab. Any one of the point actually. That's what I wanted to say. That at present, chemo is a standard treatment with IO combination is the like gold standard upfront rather than thinking a second line, third line. That's what my take. Want to say the final conclusion.
Thank you, all of you, and back to the organizers.
Yeah, thank you, Dr. Sajjan, for the excellent